audience, let me present my 9-month progress report, a new insight in cachexia prevention in gastrointestinal cancer. My name is Bettina Budai. I'm a dietitian and a first-year PhD student. My vision is that nutrition is a cornerstone in the multimodal care of all cancer patients. And my mission is to carry out scientific activity to bring innovation in the nutrition therapy of cancer. To achieve this, I have two specific goals. Firstly, we would like to investigate the risk factors for malnutrition in patients with gastrointestinal cancer. The prevalence of malnutrition in gastrointestinal cancer is up to 30 to 90%, depending on the tumor site and tumor stage. Malnutrition is a common feature in cancer. It is the consequences of the presence of the tumor, but also the consequences of the presence of the medical or surgical anti-cancer treatment. It has been estimated that up to 10 to 20% of cancer patients die due to the consequences of malnutrition rather than due to the tumor itself. Cancer-related malnutrition is still unrecognized, underestimated, and undertreated in clinical practice. The presence of it can significantly worsen the prognosis, decrease the overall survival, and increase the financial burden on the healthcare system. It is multifactorial. That means that there are various risk factors that can contribute to its development. Moreover, the exact causes and mechanisms hasn't been completely elucidated. To take into account this information, there is a strong need to investigate the risk factors for malnutrition in gastrointestinal cancer. We wanted to get the answer of the question, what are these risk factors that can increase the development of malnutrition in gastrointestinal cancer patients, and we hypothesized that there are some specific clinical and biological factors. We did the systematic search in 3 databases. Our final search key contains 3 domains. The first one related to the gastrointestinal tract, the second one related to the cancer, and the third one related to the malnutrition, and also contains various malnutrition risk screening tools. After the selection, we identified 420 eligible articles for the data analysis. This process is still ongoing, but in my presentation, I would like to show you some preliminary results where we only focus on the pancreatic cancer. The first risk factor was the biliary obstruction. In case of biliary obstruction, there is 2 times higher odds for developing impaired nutritional status. The result is statistically significant and clinically relevant as well. One of the clinical explanations can be the prevention of the flowing of the bile into the duodenum. That can lead malabsorption, that may lead to malnutrition as well. There is a clear tendency that in case of the tumor located in the pancreatic head, there is 30% higher odds for developing impaired nutritional status compared with those patients who have tumor location in the pancreatic body or tail. The result is statistically not significant. We also evaluated the different type of surgery. Patients who should undergo pancreatic duodenectomy has 2 times higher odds for developing impaired nutritional status compared with those patients who should undergo other type of surgery like the left resection or distal pancreatectomy. The result is statistically significant. We also evaluated the presence of metastasis. In case of metastasis, there is 80% higher odds for developing impaired nutritional status. This was an expected result because one of the clinical explanations can be that in case of metastasis, most of the cases patients has an advanced cancer stage that with hypercatabolic state that can more easily lead to malnutrition. We investigated the association between performance status and impaired nutritional status. There is a statistically significant higher odds for developing impaired nutritional status in case of poor performance status as well, measured with ECOG score. We evaluated other risk factors. We compared BMI more than 25 with those BMI less than 25. That means that we compared obese or overweight patients with those who have a normal nutritional state or are underweight. We cannot draw a very clear conclusion from this result that highlight the fact that BMI is not the best tool for reporting the nutritional status because it doesn't contain any relevant information about the muscle mass. We investigated the presence of comorbidities like the diabetes mellitus and hypertension. There is a clinically relevant point estimation of odds for increasing the development of impaired nutritional status in case of these comorbidities. We also evaluated the sex as a risk factor, but we couldn't find any statistically or clinically relevant result. The strength of our meta-analysis is the transparent methodology, the large patients number that we could investigate in more than 18,000 patients in our preliminary analysis, and the various cancer-specific risk factors. The limitations are that most of the studies are retrospective cohort or observational studies, and the heterogeneity that related to the population and to the definition of impaired nutritional status. In conclusion, we can say that there are risk factors for impaired nutritional status in pancreatic cancer. Knowing these risk factors, we can early detect patients who are at high risk for developing it, and we can administer the proper medical or nutritional interventions in time. Further, these risk factors can be included in the specific risk screening tool for pancreatic cancer. Further research is needed to investigate the proper mechanisms for increased risk for malnutrition, especially in pancreatic head tumor location. This is the progress of our first project. We are ready with the data extraction and the risk of bias assessment, and the data analysis is started. In my second project, I plan to investigate the effect of amino acid supplementation in gastrointestinal cancer patients. At the diagnosis of cancer, all patients have to be screened for malnutrition and offered nutritional support as needed. The presence of malnutrition in patients who should undergo oncological treatment can increase the toxicity, decrease the performance status, the quality of life, and moreover, the overall survival. There are contradictory data regarding the proper use of amino acid supplementation in cancer patients. Some data suggest to use branched-chain amino acids to improve the fat-free mass. Some suggest to use glutamine to prevent mucositis. So our aim is to evaluate the efficacy of amino acid supplementation in gastrointestinal cancer. We created the clinical question, what is the efficacy of amino acid supplementation in GI cancer patients? We are going to investigate patients with GI cancer. Intervention is going to be the amino acid supplementation. Outcome is the nutritional status, quality of life, and survival. We hypothesize that amino acid supplementation can improve the nutritional status and quality of life, but doesn't improve the prognosis. The clinical implication is the proper use administration of amino acid supplementation. In summary, I would like to my first project, I am going to investigate the risk factors for malnutrition in gastrointestinal cancer. The planned submission date is August. And in my second project, I plan to investigate the effect of amino acid supplementation. The planned submission date is by the end of this year. Thank you for your attention.
I would like to know how you're going to characterize malnutrition from all the studies, if it's going to be standardized or you're going to rely on the authors.
Thank you for the question. We standardize the malnutrition according to the measurement tool, what is used in the article. There are some tools that is measure the risk for malnutrition. We also included the measurement tool GLIM that is used for the diagnosis of malnutrition, and we plan to analyze them separately. So according this, we are going to doing a subgroup analysis.
If we go back to your search key, is that designed to identify all GI cancers? Yeah.
Yes, so we created like that the first domain is related to the gastrointestinal tract, so we try to put every organs.
Yeah. So, and you have got results only for pancreatic cancers, but not for colorectal cancers yet, or the other other big GI cancers?
Yes, yet not, but soon we are going to have separately for the colorectal or gastric cancer as well. I plan to have it, and I'm going to put together data for the whole big gastrointestinal tract, of course, if it has a meaning. So, for example, in case of sex or age.
So that is my question, or I just wonder how are you going to deal with the plethora of results you will have, because you will have lots of results, and what are you going to present, and what is going to be the strategy? But time will tell, I suppose.
Yeah, so we will see when I have already polished all of my data, but we plan to make a summary plot or something like this.
Thank you for your presentation. I think this topic is very important, and your result will help us surgeons in the future. But if I'm right, your research is not differentiate adenocarcinoma from other malignancies in the pancreas. And what I would recommend you to differentiate the adenocarcinoma from other malignancies, because the adenocarcinoma usually take place more at the head and causes much serious complaints, and the surgery is absolutely different from those that are located in the tail or the body. Usually those which are in the distal part are causes neuroendocrine problems, and the surgery is not a multi-organ resection. We can focus is just a pancreatic resection, sometimes together with the splenic part, but those that are in the head, we have to remove the duodenum and so on. So maybe it would be better to differentiate the adenocarcinoma. Of course, this is more than 90% of the pancreatic malignancies, but the 10% is absolutely different.
So so in this analysis, it is only included pancreatic adenocarcinoma and not neuroendocrine tumor. But thank you for your suggestion that maybe I can differentiate.
Yeah, sure. But we have a lot of other carcinomas in the pancreas, like cystic tumors, like intraductal pancreatic carcinoma, that can behave different than another carcinoma.
Thank you.